Hello, my name is Ravi. I'm from My Cancer Haven, and today we have with us one of the leading authorities in multiple myeloma in the United States, Dr. Natalie Callander, who's professor of medicine at the University of Wisconsin in Madison. And she's been one of the investigators who has been studying novel CAR T, Anitocel, in relapsed refractory multiple myeloma. Welcome, Natalie.
Thank you very much. It's a pleasure to be here.
So, Natalie, can you just lay the background and tell us what is Anitocel? How does it
Yeah,
differ from the currently marketed CAR T cells?
that's a great question. So we have two CAR Ts that we can use right now commercially. One is Itocabtagene of Autoleuce, and one is ciltacabtagene Autoleuce. And they have what are called a single chain variable region binding site for BCMA. In the case of Itocabtagene, that is a murine-derived binding site for BCMA, and in the case of cilta-cel, it's actually derived from a llama. And they both bind BCMA, the CAR T products bind BCMA well, but what Anitocel is the BCMA binding domain is this D domain. And the idea here is that it binds with very high efficiency, but it also does not do what's called tonic signaling. So what the heck is that? That's when one of these CAR Ts sort of binds to the BCMA receptor. It kind of doesn't let go. And there's some concern that actually that could lead to maybe the T cells not being as functional eventually, that they get exhausted. And there's also a consideration that maybe this kind of tonic signaling is responsible for some of the other side effects. And so we were very happy to be involved at the University of Wisconsin in Imagine-1 to look at this different CAR T construct.
So, what do we know about it to date? We're going to talk about the Imagine-1 study
Yes.
in a minute, but what do we know about it so far?
Right. So there was a phase 1 trial of Anitocel where it looked very promising. This came out of actually a lab in Boston initially, and they had treated about 30 patients and really saw both a very high response rate with about 79% of patients achieving a CR, and then the progression-free survival, kind of the top bar we're kind of used to seeing is with ciltacabtagene, which is right around 3 years. And so this was very comparable in this small phase 1 study.
So, what was the Imagine-1 study?
So the Imagine-1 study was a multi-institution study designed for individuals with relapsed multiple myeloma who had had at least 3 lines of therapy, and they had to have been exposed to an IMiD drug, meaning either lenalidomide or possibly pomalidomide, a proteasome inhibitor such as bortezomib or carfilzomib, and lastly, an anti-CD38 antibody. And they had to be not responding to their most recent type of treatment. And about 129 patients were initially enrolled. And as is the case with many CAR T studies, particularly when you have a patient population like this, so these are people who are in need of treatment, things are going on with them. So they were able to go ahead and actually treat out of that initial 129, 117 patients.
So, what was the demographic of the patients enrolled?
Well, this is actually, I think, one thing that's very exciting about this particular study, because the population, it's the median age is 64. It was pretty much 50-50 men and women, but in terms of non-Caucasian participants, did a lot better than other CAR T studies, and that's been a criticism. And so about 15% of the patients self-identified as African American and 9% as Asian or other, which is really kind of a big deal. And then then we know that these individuals were really, most of them had a pretty large burden of plasma cells going into this. About a third of them had at least 30%, and about 20% had more than 60. And by definition, they all had to be refractory, meaning not responding to their last round of chemotherapy. And a large number of these individuals, about 41%, had been exposed to both proteasome inhibitors, both IMiD drugs, and a CD38, meaning that they're a difficult to treat group. And we know from other studies like the Mammoth trial that we participated in that an individual like that, their average time, their median progression-free survival with standard treatments is right around 4 months.
So, what did we see in terms of the responses?
Well, so the responses were really pretty good. The overall response rate was 96%. And most of those individuals, about 3/4 of those responses were stringent complete remissions or complete remissions. And like other CAR T studies out there, the time to see a response, it's very quick. It's within a month. And over time, patients actually improve their response. So it took about 3 months for individuals to get to a CR. And furthermore, the 24-month progression-free survival looks great. It looks at 61.7%, which is excellent and very much rivaling that of what was seen with ciltacabtagene and doing better than what was seen with itacabtagene. And so far, the median survival hasn't been reached, nor has the median progression-free. So that means that we're expecting people to do better.
Very encouraging.
Mhm.
And obviously, these days, no presentation is complete
Yeah,
without talking about
right,
MRD. So, what
right.
can you tell us about MRD
So,
here?
so the MRD negativity rate is very high, and it's 95% when checked initially. And then, probably more important, we know now that it would be best if people have not just one MRD negative time point, but multiple. And so we know that there's about 83% of patients who had sustained MRD negativity, meaning that they kept it in this particular trial for at least 6 months, which is very noteworthy.
And what can you tell us about the typical side effects that we worry about with CAR Ts,
So
CRS, and ICANS?
Right. So I think what has really gotten a lot of attention appropriately is that we know that most individuals receiving BCMA targeted CAR T are going to have some degree of CRS, usually fever. And I think that we've come to expect that. Now, the timing is obviously a little bit different from CAR T product to CAR T. We know with itacabtagene, CRS incidence is pretty early. It's usually around day one. With ciltacabtagene, it's typically later, 6 to 7 days. For Anitocel, it was right around 4 days, and the majority of what was seen in terms of CRS was very minimal, usually no more than change in blood pressure at the most significant, or perhaps some nasal oxygen. But the vast majority had very low level CRS, 95%, that was gone in 10 days. And patients did get some of the supportive care we used, but there was really, out of the 117, there was only one grade 5 event, which is very encouraging. And then I think what has really gotten everybody very excited about Anitocel is we know that neurological side effects can occur in sort of two, maybe three groups. And so one is the immediate, what we call, immune effector cell associated neurotoxicity, where very soon after CAR T, maybe when the first 10 days to 2 weeks, people can get things like confusion or maybe headache. Rarely they can have things like seizures. These are very serious. We're getting better at preventing that from happening. But then there's another group where people can have these nerve palsies that we call them technically cranial nerve palsies, but they look like a Bell's palsy. That has been reported in ciltacabtagene. And then finally, there are these late neurotoxicity events where people develop often movement disorders that can look something like a Parkinson's, but are very difficult to treat and in many times don't improve. And so one of the things that I think was very exciting about Anitocel is the ICANS rate was very low. And then so far, there really hasn't been any sort of late neurological toxicity, which has been fantastic.
And I guess there's some talk about colitis as well.
That is the other. So colitis is another CAR T mediated phenomenon, and it starts to occur often a couple of months after the CAR T, where people get diarrhea and they get abdominal pain. And we're still trying to figure out how to treat that when that occurs. And we are really not seeing that with Anitocel as well, which is fantastic because that entity, that colitis, it's difficult to treat and has unfortunately led to deaths of some individuals.
So what about any other safety signals?
Yeah, so nothing new. So we expect individuals with CAR T, many individuals, partly because they may have some lower counts from their myeloma involvement in the bone marrow. Most of the time, we expect people with CAR T, undergoing CAR T, to have low blood counts, so low white count, low platelets, and low red cells. There is going to be a degree of transfusion that occurs. So there was no more than expected. In fact, probably a little bit less. We also know that because patients have very low levels of normal antibodies, meaning they become what we call hypogammaglobulinemic, there was some infection, but nothing that seemed to be out of the ordinary. There was a few instances of urinary tract infection, respiratory tract infection, and because of when this trial was going on, there were a few cases of COVID-19. And then there were just some electrolyte abnormalities. Again, nothing particularly out of the ordinary. And then sometimes there are side effects that are probably more attributable to the lymphodepleting chemotherapy that occurred rather than the CAR T itself.
So when do you anticipate this becoming available to patients?
Well, we know that there's what's called the PDUFA date coming up in December, and I think at this point we are expecting that very shortly after this will become available. I think where we expect it will probably be labeled for 3 or more lines of therapy because of the way Imagine-1 was set up. Now, there is a large Imagine-3 trial going on that is taking patients with as few as 1 lines of treatment at the time of relapse, and that is being compared very appropriately to regimens like carfilzomib, dexamethasone, and carfilzomib, daratumumab, dexamethasone. That is underway and is going to take a while to read out. So we assume that the first indication will be for people who've had probably 3 or more lines of therapy, but I would imagine probably at the beginning of 2027 we're going to see it available.
And what is what we call the vein to vein time with this product? Like how fast does it become
Yeah,
available to our patients?
it is doing pretty well. We anticipate that it's going to be probably 2 to 3 weeks potentially,
Hmm.
and that the manufacturing time does seem to be coming in pretty quickly for these for the individuals in Imagine, and so we're hoping that that becomes the same time frame. And there's been various iterations of Anitocel. It is going to be probably put forth by a company that has a lot of experience in CAR T manufacturing, and I think that will really help get this to more people who need it.
So when it does become available, how do
Yeah.
you anticipate using it?
Well, I think I think if the neurotoxicity and the colitis signal really holds up, I think it's going to probably for later line CAR T become the preferred product. I think both because of the nice response, the PFS, and the overall survival signals that look like they're emerging. I wouldn't be surprised if this becomes the choice in that particular group of patients.
Well, I really want to thank you very much for talking to us about this exciting product, and hopefully uh, all the research that you and your colleagues are doing will lead to even better products in the future.
Yeah, and obviously for all the research that you yourself are doing, and I think this is a very exciting time in multiple myeloma. We're so happy that we have more and more things to offer individuals at any stage of their myeloma. Certainly something different, as you and I know, that maybe 20 years ago where we really didn't have a lot of things. So this is terrific.
Thank you very much, and hopefully have you back to talk about those
Okay,
exciting developments in the future again.
that would be my pleasure.
Thank you.
Thank you.